Welcome to Let's Talk, a place for straight talk, hard topics, and smart people. I'm Sue Wallace, CEO of Oximetry, and thanks for joining me today. I'm very happy to be here with James Crowley and Dustin Osborne to talk about radiopharmaceutical therapy in the clinic. I don't know if you've thought about this in your departments, but you've got me thinking there that, in the radiation oncology world, these are complicated workflows. They have dosimetrists, and then the physicians come in and contour the tumors, and then you've got the physicists checking out, and people are in and out of these treatment plans before it's done. And there are quite a few companies who've built these department level, workflows, software products that are workflow managers, the old whiteboards, but in the computer, right? Where is this patient in the process? How do we get it done? Do we need those in these theranostic clinics?
Well, that's what we do. We actually use, we use a Teams interface, but that's what we created inside. So we have a RBT group, right? We call it RBT Flow. And, but that flow group essentially works like a magnet board where you're stepping the patient through the process. And we actually have then any new patient that hits the workflow, then we have all their information sort of building up as they step from one place to the other. So as they go through therapy, we have all the notes, all the attachments, all of the stuff that we've done, and that's all right there in that case.
And does that carry through when they come back for their second or third cycle? Is it sort of the same whiteboard, or is that?
Yes. No, it's the same.
So you can still see where that patient started.
All the way until they're completed. And then once they're completed, they drop off into a completed bucket.
Yeah.
But in the completed bucket, I can pull up them, and I can see everything that we did from start to finish, which is a really nice flow.
You should go commercialize that.
Well, I was invited to work on a project with Epic, because I think one of the it's very early in that, but they recognize it's not just the dosimetry workflow is complicated. All of it is. The orders you need, the pre-meds you need, the documentation, nurse vitals, all of these things. It's complicated. And it's one of the general problems of imaging is, when you look at the typical electronic medical records, they have these kind of islands, right, of the typical things you need. And for example, Epic uses Radiant, right, for imaging. But in oncology, they use Beacon. Well, we're trying to take some of these tools in Beacon and move them over into imaging because we're not used to patients coming back.
Yeah.
For multiple things. I mean, you think of these, have a consult. I mean,
what would we talk about?
Yeah, we like many others, I feel like we're moving to the concept of having a clinic, having that style of, and then you run into, well, we need that to be an ambulatory site, not a HOP site, so that we can do a consult, do an H&P, have the clinician, the AU work up the patient. It's their patient. And then they're ordering the exams now. They are the owner, they are responsible for that patient. So then, the Stark Law things are not true anymore. So you don't have self-referral. You do need to be able to defend what you're doing.
Yes.
But you're ordering the labs, you're ordering the imaging tests, the dosimetry, and you need this workflow. And I think our electronic medical records, because we have a Teams type thing now too, but I want it in. I want it in the record.
Borrow from, because I don't know what's in Epic. Can we borrow from medical oncology, not radiation oncology? It's because it's really a meta protocol, right? Chemo protocol, right? Essentially, yeah. Right. Because I was thinking, in external beam, it's been a strange history where because of these mature oncology information systems that were developed early on, Epic never really came down as deep into that space. So this would be a gap, but they are in chemo, so we're good, right? Okay, interesting.
And that's really what's missing. I said that workflow step, in our systems that we use there's no workflow step at all. So it's all disconnected. There's nothing I can use to track the patient through any process. I can bill and I can code through those systems, but there is no patient tracking mechanism for that. So that's why we had to build, our own system to be able to deal with that. And I do think going to like the dosimetry stuff, like with the physics side, I do see it very similar, like radiation oncology, where again, you'll have a physicist that reviews it. Because one of the things we were talking about this, this week is, even if you have the technologists and they're able to do the ROIs and they're able to get that out, the real trick comes down to the model that's used.
Oh, sure,
and that is where you've got to, and that's where you got to be careful that's where the liability comes in really, because the dose changes so drastically depending on which model you choose. And there's sometimes some really specific reasons from a physics perspective that I would, not even from a physiological perspective, but just from a pure math perspective, that I'd be like, I'm not using that one, And so it's, that is, some of those things, I think it'll be very similar to like radiation oncology at some point where it is like, yeah, and you check it. Exactly. Same with like Y90s, right? We always keep eyes on a Y90 when they come through. And we're not, saying yay or nay, but it's like we're making sure the stuff got
Well, you're saying you're not
documented
throwing up red
correctly.
flags, and that's
Yeah,
it's good
yeah,
that
or
you were there.
calculations off slightly, because again, these things still are done in spreadsheets. I mean, Y90's been around for, for 2 decades now, and it's you're still working in spreadsheets for things. So it's that's funny.
But it's funny on dosimetry. I mean, because nobody would I don't think people who are doing, the Y90 microspheres, whether it's either of the vendors that are currently available, they wouldn't dream of not imaging that. But there's not a thing they can change. They've done what they've done. And that patient does not have a long life expectancy. So it's like, in the idea, we have to change our thought. Everybody wants to know what's happening with the Y90 microspheres, but, frankly, these patients pass within 6 months, typically. So you're not going to likely give them something else, but it doesn't, it's the same problem with the Pluvicto and the DOTA. Like, we still should know.
Yeah.
It's just part of the medical record. It just needs to evolve.
Well, as we've discussed, obviously, is that if you think about nuclear medicine, right? There's not a single tracer that we inject, and then we don't immediately figure out where it went. And so, but the one where we could actually hurt someone in some way, people are like, no, we don't need to see where that went, which is a strange concept, man. And that's where it's hard for me to. I have a little bit of a dissonance with the pushback on, well, why should we image that? It's like, well, because you image everything else. I mean, there's a very few number of procedures that we would do in nuclear medicine where we would not, within an hour or two or few hours follow up with a scan.
Yeah, it's so funny to think. I mean, how simple that is, but you have no idea.
James and Dustin, I hate to stop this conversation. There's so much here to learn from what your in the clinic experiences are. This has been great, but thank you so much for joining me. And so that's my official close. Let's talk again.
Yeah. Very good.